Good morning. My name is Raul Rosenthal. I'm at the Cleveland Clinic in Western Florida. And I would like to start this presentation by thanking Professor Yang from the University Hospital in Seoul, Korea, a world leader, if not the leader in gastric cancer, and obviously also David's Dream Foundation that is doing and has done so much for those patients that are suffering from this disease. The topic I was assigned is to discuss with you today how you can make a decision and choose between an open, minimally invasive laparoscopy or robotic surgical approach when managing gastric cancer. Let's keep in mind the statistics. Worldwide, gastric cancer is the fifth most common malignancy. 1.2 million new cases a year, 15 per 100,000 individuals are affected worldwide by gastric cancer. However, when it comes to United States of America, gastric cancer is the 15th most common cancer. And the incidence continues to decrease to only 28,000 new cases a year. And this is because we are recognizing and managing H. pylori infection at an early stage. You can see here more clearly the numbers for Asian Pacific region at the very top and the United States of America nearly at the bottom above Africa. So rare in the United States, very common in the Asian Pacific region when we have 20 to 36 individuals per 100,000 affected by this disease, while in America or even in Canada, it's only 10 individuals, 0 to 10 individuals per 100,000. There are two new terms for you to understand. One is minimally invasive or laparoscopic surgery that has been used for gastric cancer since 1994. And the other one is the robotic approach that is being used since the year 2002. Obviously, as we've been doing for over 100 years, surgery is done with an open technique also, doing a larger incision or a larger cut. But the results are outstanding if it is not related to the wound itself. So how can we choose in using such a sophisticated machine or using the old-fashioned open approach? See that even in the 15th century, Leonardo da Vinci thought about a robot being a possibility to replace the human arm. And this is what robots are nowadays. They cannot carry out a procedure single-handed. They cannot operate alone. It is a human that needs to move them. In other words, it's a laparoscopic, human-driven, remote-driven procedure. The first tele-remote directed procedure was done for a gallbladder in 1997. And here you can see how a robotic surgeon works, away from the operating table where other people are assembled. The number of publications is going through the roof, as you can see, on a yearly basis, over 2,000 in the year 2016, and only a couple of hundreds in the year 2005. And this is a problem because you need to make a decision and you do not have access to all the scientific papers that have been recently published that show in reality that the robotic surgery, when compared to the laparoscopic surgery, has no advantage. There is to date no prospective multicenter randomized controlled study, which is the way we like to demonstrate that one technique is better than the other, that shows that a robotic procedure is superior to a laparoscopic one. Now, I want to caution you that you don't need a laparoscope or a robot to be good. And you could be also a terrible surgeon with a laparoscope or a robot. There are outstanding robotic surgeons and there are outstanding laparoscopic surgeons, as there are terrible surgeons with a laparoscope and terrible surgeons with a robot. So how can you make a decision? How can you choose? Well, there are, I think, four fundamental principles that you need to tag along to make a procedure choice. And those are based on surgeons and hospitals' honesty, integrity, and respect for our patients, for your suffering. The first principle is that whatever decision we make as physicians and hospitals, your interest is the number one. The second decision is that whatever we recommend you as a best treatment modality, it has to be supported by best available evidence. And I just show you, no evidence shows that the robot is better than a laparoscope. The third principle, it is imperative that any intervention or procedure is properly compared with others that are accepted methods. And the fourth principle, obviously, do not fulfill those who do not fulfill those three must be held accountable. What is the problem? Well, the real problem is that in the United States, if you want to start a new drug, a new intervention, the FDA will monitor that device or that drug. They will make sure it's well indicated, and it's safe, and it's efficacious before it gets distributed to you. But if a surgeon decides to change their technique or use a new tool, when and how and if, is he good at that or not, there is no regulation. In addition to that, technology is advancing rapidly, steady streams to opportunities for us to innovate. We want surgeons to publish and present, become known, help patients, but also help our own institutions. You get referred by physicians that really have no idea if this surgeon is good or bad, but just because they know them, that he's using the robot. And obviously, we have to be credit that we all want medicine to get better. Surgeons have that drive to improve, to do research. They are inquisitive. They're curious. How can I do better? But there is another problem, and that is the interaction between the media and our patients. The media puts out there anything, what surgeons want to put on Facebook, on Twitter, on YouTube, and you are misled because you think that if he or she has a laser probe or a laparoscope or even a robot, they're going to be doing better. This is Dr. Macquarie from the Johns Hopkins School of Medicine that published in the Journal of Healthcare in 2011 that hospital websites should be a trusted source of information to the public. But what really hospitals are doing now are tooting the robotic surgery without solid scientific claims. And they're saying that they're creating content with disclosures of the official hospital website. There are more than 400% increase in this kind of publications in the literature. And they're saying that, the robot is better. And this is perceived by you that if you go to a hospital that has a robot, they're cutting edge. They're great. Well, I can tell you that in 2021, if you have the dollars, any hospital can have a robot to market them as cutting edge. 89% of these sites said that robotic surgery was better than conventional. And I just show you the data. Robotic surgery is not better than conventional surgery. They say that it's less pain than laparoscopy, shorter recovery, and less blood loss. This is not true. There is a gap. And that gap is widening because of social media and what's out there for you to read. And we need to control this because at the end of the day, when someone is innovating, patient safety should be at the top. And we can no longer enjoy innovation in an unmonitored status. We need to protect you. Otherwise, you become a research subject. Evolution and evaluation should be done simultaneously. This is a manuscript published in the Annals of Surgery, our #1 journal in surgery in 2017, that looked at what surgeons are publishing. When you publish a paper, you need to disclose the conflict of interest. And what's interesting is that if you are having a conflict of interest, there is more likely to have favorable results with less complications and better conclusions. Well, they look at 458 statements. In the first one, there was a declaration statement present. In the other one, there was no declaration statement present. In other words, here the surgeon said something. If he or she is getting money, here the surgeon said nothing. Now, here you have the results. When the declaration statement was present, in 82% of the cases, funding was not declared. So they say they're not getting money. 63% of those said that they are getting money. When there was no declaration absent, or declaration was absent, 52% were receiving money. They didn't say anything. They didn't say they're getting it or not, but they found out in this manuscript that they were getting money. So in those who had a declaration statement present, 94% of those declared that they were not getting money, while 21% of those were getting money. And 22.8% of those who had the statement absent were getting money as well. So you see that it is very difficult to trust physicians when they are reporting. They are not a credible source. And it is true that in 2021, progress depends on the unreasonable man. You need to think not out of the box, but without a box, because we want to make medicine better, surgery better. But we have to be very careful because, as Fyodor Dostoevsky said, that man has predilection for systems and abstract deductions and is ready to distort the truth intentionally. He's ready to deny the evidence only to justify his own logic. So, in summary, be careful who you follow. Do due diligence. Try to find a quarterback, a doctor you know that can help you find out who is the best surgeon, either with a laparoscope or with a robot or with open surgery. And look at these soldiers following this doggy who says, can't smell a thing. Be careful who you follow. Be careful how you choose. And obviously, Debbie's Dream Foundation is here to help you to make the right decision. Again, I thank Professor Young and I thank Debbie's Dream Foundation for this unique opportunity to present here today. Thank you.